Our project is on juvenile type 2 diabetes by Monica Webb, Katrina Anderson, and Tara Jett. First of all, let's meet the patient, 15-year-old Molly and her mother Sarah Jane. Sarah Jane brings her daughter to a neighborhood medical clinic complaining that for the past few months, Molly has been sleeping more than 10 hours a day. In the beginning, Mother Sarah Jane thought the fatigue was related to Molly just being a teenager. Both mother and daughter have only visited the clinic a few times for problems that required a short-term illness, maybe antibiotics. Molly is young. She does not have much of a medical history aside from obesity. She has no surgical history or known allergies. Molly does not take any medication except for an over-the-counter pain reliever on a few occasions. She denies smoking, drinking, and drug use. Her mother states there is a family history of high cholesterol and high blood pressure on her side. On the father's side of the family, there is a medical history of heart disease, high blood pressure, obesity, and diabetes. The nurse assesses the patient and finds that she has had blurry vision for the past few months, felt extremely tired, suffers from shortness of breath, and lacks adequate physical activity. Further assessment reveals Molly has been urinating much more frequently and is constantly thirsty. Based on the assessment and Molly's body mass index of 37, the nurse suspects juvenile diabetes. Critical thinking question number 1. What is the pathophysiology of juvenile diabetes? Type 2 diabetes usually does not appear until after the age of 40, but recently has begun to show up in children. To break it down, if a person has type 2 diabetes, their pancreas still makes insulin, but the body does not produce enough of it or is not able to use it effectively. Insulin resistance happens when cells such as muscle, liver, and fat do not respond to insulin, even when the levels are high. In fat cells, triglycerides are instead broken down to produce free fatty acids for energy. Muscle cells are deprived of an energy source, and liver cells fail to build on glycogen stores. Obesity and lack of physical activity are thought to be the major cause of insulin resistance. So what is the next priority of the nurse? The nurse should obtain orders to draw labs for blood glucose levels and hemoglobin A1C to get a better picture of the patient's current glucose levels and also a snapshot of the patient's history.
Hi, I'm Tara Jett, presenting physician orders for our patient, 16-year-old Molly, with juvenile diabetes type 2. Physician orders will include fingerstick blood glucose level to check Molly's current glucose, O2 via nasal cannula at 2 liters for her report of shortness of breath, urinalysis, drug screen, and pregnancy test to check. While hopefully unlikely, at 16, Molly could possibly have any of these things. 500 normal saline bolus for her dehydration and a continuous infusion of 125. CBC, BMP, and a hemoglobin A1C, all to check for electrolytes and current levels of blood glucose, and A1C to check her 3-month output. IV potassium sliding scale per facility standing orders, EKG 12 lead, and continuous heart monitoring. Recheck blood glucose after 2 hours to ensure that hopefully it is coming down and not shifting and going up. Notify and start insulin drip if blood glucose greater than 400 times 2. Why should potassium be checked and administered prior to giving insulin? Giving insulin to patients with a serum potassium, a blood potassium of less than 3.5 can cause serious intracellular shifting of potassium and fatal arrhythmias, which is why a 12 lead and a continuous heart monitoring is also necessary. What would the most significant findings in urinalysis prove? Ketones, signifying DKA, pregnancy, and drugs.
My name is Katrina Anderson, and I'm going to review the stages that Molly currently is in. So she's in stage 1, the admission condition. She's a 15-year-old female admitted with type 2 diabetes. Her blood glucose level at this point is 215, and her hemoglobin A1C is 8%. Her vital signs are within normal limits. So For this stage, nursing interventions would be to educate on lifestyle changes such as diet and exercise, also referring to a nutritionist to discuss dietary options would be another intervention, educate on diabetes causes and treatment, and have patient demonstrate blood glucose monitoring. The second stage is nursing interventions that are required once her blood glucose level increases to 245, her hemoglobin A1C has increased to 9%. So at this stage, nursing interventions would include placing the patient on metformin per the provider's orders, educating the patient on checking blood sugar in AM before meals and 2 hours after meals and record in her log. Encourage at least 60 minutes of exercise daily and limit screen time to 2 hours daily. Education regarding healthy meals and educating on signs and symptoms of hyperglycemia and hypoglycemia. The next stage is patient improvement. So in this stage, Molly's hemoglobin A1C has decreased to 7%. Her blood glucose is 200 and her BMI is 30. Nursing interventions at this stage is to inform patient of importance to follow up with scheduled appointments and bring blood sugar log to each appointment. Educate on importance of taking medication as prescribed, as well as adhering to diet and exercise regimen. For critical thinking questions, what should Molly do if she develops hypoglycemia? Molly should be educated on signs and symptoms such as shakiness, sweating, chills, clamminess, irritability, confusion, increased heart rate, sleepiness, blurred vision, and headaches. She should consume 15 to 20 grams of glucose or simple carbohydrates such as glucose tabs, a half a cup of juice or soda, or hard candy. She should recheck her sugar after 15 minutes. If hypoglycemia continues, she should repeat the steps above. Once her blood sugar returns to normal, she should eat a small snack if meal is more than 2 hours away. The next critical thinking question is, what nursing diagnosis would be appropriate for Molly? Anxiety related to lack of knowledge due to diabetes management, risk for activity intolerance related to fatigue and muscle weakness, risk for impaired skin integrity due to poor circulation, risk for unstable blood glucose levels due to newly diagnosed, and then a knowledge deficit related to dietary and exercise needs. And that's it for my section.